Hi, I'm Gantt Galloway. I run the New Leaf Recovery Foundation. We do risk reduction work, and one of the things we do is distribute Noloxone to treat opioid overdoses. There's a lot of attention on opioids these days. A lot of people have problems with opioids, addiction and overdoses, but there's addiction to all sorts of substances. And a lot of what applies for addiction treatment in general applies to all substances. I get asked what the worst addiction is, what the worst substance is, and my answer to that is the worst thing is the one that got you. We now have over 40,000 people a year dying of opioid overdoses in 2018. Opioid overdoses are simple to treat, and I'm going to explain how that's treated, demonstrate kits. These kits are fairly widely available, and they're different forms. We distribute these in bags, and what's in the kits: 2 syringes and 2 ampules of this medication called Noloxone. Used to be sold under the brand name Narcan, so you may hear both terms used, and I may go back and forth a bit using both terms. We'll also include a card signed by our authorizing physician, Dr. Alex Stallcup. This will demonstrate that one has been trained in use of this medication. If your vial of Narcan is expired, we will happily replace it. Just contact us. However, I can't advise you to use expired Narcan, but modern medications, what happens when they expire is that they become less potent. They're not becoming toxic in any medication that we know of. Sometimes these expiration dates are conservative. Expiration dates are designed to kick in the worst case scenario when the medication drops below 95% potency. U.S. Armed Forces have done testing on Noloxone and found that it lasts 7 years beyond its expiration date. If it expires, we'll replace it. Opioid overdose, it can be a slow downward spiral. There can be hours in which one can evaluate and intervene in this. Noloxone is a very effective medication for treatment of opioid overdose. It is extremely safe. So if somebody comes in the emergency department and you're not sure what's going on, it might be opioid overdose, you're concerned that they're on the brink of death, you have no hesitation about giving Noloxone. It's not going to hurt somebody in terms of risking their life. Pretty much everybody who gets Noloxone who's having an opioid overdose survives. It's in the high 90% range. The one possible downside to giving Noloxone is if one gives too much and somebody is tissue dependent on opioids, and one goes beyond just reversing the overdose and getting them breathing again, it is possible that it will make them feel sick and have withdrawal symptoms. And withdrawal symptoms from opioids are generally not life-threatening, so this is just a discomfort issue. There is also this nasal formulation. I'll open it up and show you that this is a single use, don't test it out, but it just gets held. It gets held like this, put up the nostril of the person who's overdosing, push up on that, and a single dose is administered up the nostril. And ordinarily that should be enough to overcome an overdose. These are a little more expensive. These are too expensive for us to distribute in bulk. We owe our training to the DOPE project in Oakland, California. So S.C.A.R.E, stimulation. You don't know if somebody is overdose, unconscious, asleep, rousable or not. So you want to establish this first before you go through more serious steps. So you try to stimulate somebody. If you know their name, hey, George, Jane, are you awake? Wake up. You can say, I'm going to Narcan you. I'm going to give you Noloxone. If somebody has had opioid addiction and has gotten Noloxone before and has gotten a little too much and had some bad reaction to it, some uncomfortable reaction to it, not dangerous, but uncomfortable, they may wake up If you can't rouse them that way, a way to stimulate them to cause pain without causing damage is to rub your knuckle on their breastbone, a sternal rub, and that hurts, but it doesn't damage people. If they're still not responding, then the most important things to do are to call 911. It is not necessary to say, this person is overdosed. You, in fact, don't know. You can never know for sure what's going on. You can have a good idea, you can have a very high index of suspicion, but something else may have happened. Even if you saw somebody use drugs 5 minutes ago, it's still possible something else has happened in the meantime. Just call 911. Person is unconscious, not responsive, having trouble breathing, not breathing, whatever you tell them, just give them the facts as you are sure of in those respects. The third is airway. You check and make sure that their airway is clear. So you make sure that they are lying down, flat on their back. You can do a chin lift and head tilt back, and if the airway is straighter, it's easier to breathe. If somebody is CPR trained, you will have learned all this in CPR. So I do recommend that. If you think you might need to use Noloxone, getting trained in CPR is a fine thing as well, because that will give you some of the steps you need. It's uncommon to have adverse reactions to Noloxone. Precipitated withdrawal can include waking up, being irritable, vomiting. These are uncommon reactions, but if somebody vomits, you do want to turn them on their side so they're not breathing the vomit back in. See if they're breathing. If it's not obvious whether they're breathing enough, you can put your ear to listen for breathing. You can look at the chest to see if it's rising and falling. Open the mouth, look and see if there's anything. If you see anything in the mouth, just scoop it out. See if that takes care of the problem. If they're still not breathing, and if they're not, when I say not breathing, that means not breathing fast enough. If they're non-responsive and they're not breathing at least once every 5 seconds, then you want to do some rescue breaths. Again, pinch the nose, blow into the mouth, a normal breath. Hopefully you'll see the chest rising and falling if the airway is open. If you don't have Noloxone, calling 911 and doing rescue breathing is great. Noloxone is really just kind of icing on the cake. But if you're breathing for somebody, they need to breathe. Whether you're doing it for them or whether you give Noloxone as an antidote and they start breathing on their own, either one is okay. So opioids have a variety of effects, different parts of the body. There are obviously some euphoric aspects to their effects, cough suppression, slowing down the gut, so they're useful for treating diarrhea. Conversely, they induce constipation. One unfortunate additional effect, though, is that they suppress breathing centers in the brain. And this is the mechanism by which they kill you. So the respiration stops first, and then the heart falters and stops. The heart is still beating, give the respirations, get oxygen back in the system, and that will keep the heart beating. Opioids in combination with other medications that also suppress breathing are more dangerous. So those other medications could include alcohol, the class of drugs known as benzodiazepines, which is Valium, Xanax, Klonopin. The Noloxone works really well. It gets on the same receptors that the opioids do. It basically bumps them off. And then once the opioids are not on the receptors, they're not working anymore, they're no longer suppressing the respiration. So this Noloxone works only for opioids. Other sorts of overdoses will not be made worse by Noloxone, but will not be treated by Noloxone. This is part of why it's important to call 911 regardless, because you don't know. It's an opioid-only overdose. Noloxone is a relatively short-acting drug. There are some long-acting opioids. Usually if you give somebody Noloxone and they wake up, they come back, they're doing fine, they are going to be fine, but there are some opioids that are long-lasting. The Noloxone may wear off. There is the possibility that someone will get back into trouble and even die after you think you've taken care of the problem. Now, Noloxone does not work immediately. It may take minutes to circulate through the bloodstream, get to the brain, get the opioid off the receptors. It's a question of balance, of how much of the opioid is suppressing your respiration versus how much naloxone are you given. The next letter in our S.C.A.R.E acronym is E. You evaluate. Are they doing better? Sometimes you get them with a better position for the airway. You make sure that their mouth is clear. You give them a few rescue breaths. They will improve. But if they haven't, you then need to evaluate for yourself, do I have naloxone nearby? Can I prepare it? You don't want to, if it's, down the hall, around the corner, in the back of a closet, and it's going to take you minutes to get it and bring it back and prepare it, you just want to keep doing rescue breathing. If you have it in the immediate vicinity, you can go grab the kit, bring it back, give a couple more rescue breaths, and then prepare the medication. The M in S.C.A.R.E, you give a muscular injection. It needs to go in the thigh, not the eye. Ideally it goes in a muscle or a vein. You don't want to take the time to try and put it in a vein, but if it goes in a vein by mistake, you don't need to draw back on the syringe and make sure you're not in a blood vessel. If it goes in a blood vessel, not a big deal. Well, this is a practice pad for injecting into. One opens it up. The Narcan comes in these little flip-top ampules. These are super easy to open. Pop, the top is off. Get that out of the way. Pull the needle cap off. If you're needing to give this medication, you may find your nerves a little bit jangled. You don't want to be having two moving objects at once. Just take the vial, put it down on a flat surface, put the needle into the vial. These needles are long enough. You just put it all the way to the bottom, draw up the naloxone. Simple, easy. Make sure you have it all up. It's just a jabbing motion all the way in and then inject. Now when I say muscle, you'll have somebody on their back so you can check their breathing, do some artificial respiration. The thigh is a large muscle, convenient to get to. And so this will just be jabbed into somebody's thigh. You're giving naloxone, it's an emergency situation. You don't worry about taking the clothing off. The needles are sharp. Don't worry about cleaning the skin. The risk of infection from any single injection is low. Of course, in Pulp Fiction, the medication was injected directly into the heart. It was the wrong medication in the wrong place. Very traumatic, very good for the movies. Overdoses are not always as they appear to be in the movies, though. They're not always quick. The thigh is fine. Large muscle. Muscles have good blood supply. There's no reason to put it anywhere else, ever. Remember, you have now a contaminated needle, a sharp, and you want to be sure not to hurt yourself. These are safety needles, so if one simply pushes like that, the needle is now covered, contained. So as soon as you give an injection, cover up the needle. This now cannot be gotten free again. As safe, you can put it down. You can get back to taking care of the person who's overdosing. After one administers the naloxone, you immediately go back to doing rescue breathing. Wait 3 to 5 minutes, which in the moment may seem like an eternity. If you're in a city, waiting several minutes, you are getting close to the time by which paramedics will be responding. In 3 to 5 minutes, they haven't responded, they're not breathing on their own again, you can give the second dose of naloxone. There are 2 doses in each kit. Typically, that's going to be enough. Again, if you are doing rescue breathing, if you have 911 on the way, you have done the important stuff. The last E in S.C.A.R.E is evaluation and support. Are they breathing on their own? You do keep in mind that it wears off in roughly an hour. So you don't want somebody wandering off. It's possible that somebody, even from these doses of naloxone, will have some discomfort. That discomfort is, they might call dope sick. They might call opioid withdrawal. Their reaction might be to want more opioids, and that is just the wrong thing. For a couple of reasons, one of which is that the naloxone wears off after about an hour, and if they take more, they may be able to just overcome the naloxone you gave them. And it will also put them at greater risk once that hour or so is up that the naloxone works for. Just tell them what happened, reassure them. You weren't breathing, I gave you naloxone, it's not gonna last very long, you'll be okay, hang on, this is temporary. So just give them support. I've been in the uncomfortable situation before naloxone was widely available. For example, having a patient in my office who was nodding off and was breathing 3 times a minute. And that's not enough. And I could rouse her and I could get her breathing again, but I didn't have naloxone. I had to just call 911. It worked out, but it's reassuring to have this medication available. When you are in the moment and you need to give naloxone to somebody, you will have this S.C.A.R.E brochure, and you will also have this even handier reference card. 1, call 911, 2, do rescue breathing, and 3, give naloxone. Get this training now, review it again in the future. There is also a nice online training, getnaloxonenow.org. I highly recommend that as well. So there is a Good Samaritan Act that if you call 911, you are supposed to be immune from prosecution for possession of drugs not for sale quantities, being under the influence, or possession of paraphernalia. Law in California and many other states is supposed to protect you from being arrested. If you act with reasonable care, again, if you inject in the thigh, not the eye, and you give naloxone, you are immune from any sort of civil liability as well. You can't be sued. It does give me cause to reflect that we have had naloxone on the market as a treatment for opioid overdose in hospitals, for example, for many decades. We're just recently, as of 2018, getting it out in communities. It does make me wonder how many other risk reduction interventions we should be doing that we're missing. I would point out that for those who end up needing naloxone because they're addicted and they have had an overdose in the course of their addiction, that it is a little bit sort of after the horse has gotten out of the barn. There are effective treatments for opioid addiction available. They are grossly underutilized in this country and to a large extent unavailable. And these are medications like methadone and buprenorphine, which work really well. The best medication is the one that you give once. Has no side effects, complete cure rate, and only requires a single administration. There are such medications for some conditions, but there are a lot of medications that you do give on an ongoing basis, like insulin for diabetes. We would prefer better treatments for diabetes, but nobody says that diabetics should stop taking insulin. People who are opioid dependent may actually need to be on a treatment for opioid dependence, a medication treatment for opioid dependence for years on end. It does look like short-term use of those treatments is probably not helpful, may actually increase mortality in people. The treatments for opioid addiction that are given for short-term, those do need sustained use. Those are some of the most effective treatments we have in Western medicine. Methadone reduces death rates in opioid addicts 80% and makes their lives better in other ways as well. The concern has been raised that because Narcan is available, that people will feel safer about using opioids, be more inclined to use opioids, or even at the extreme sort of push the limits and know that they can be brought back. This harkens back to arguments used about distributing condoms to young people, and it's been shown that rather than promoting sexual activity, that distributing birth control delays sexual activity. This has also been raised as a concern with needle exchange, where one gives clean needles to people so there won't be HIV transmission. This seems to make people more receptive to treatment, to give people clean needles. One could also talk about seat belts. You know, seatbelts make driving safer. Does this mean that people drive more recklessly? No, people don't want to get in auto accidents. People don't want to have overdoses. People who have the disease of addiction do have a different relationship with drugs. They continue to use despite adverse consequences, including the risk of overdose, and that is really the cardinal feature of the disease of addiction. But that doesn't mean they want to overdose. This is a mix of different sorts of opioids and different contexts of use. So certainly people who are addicted, who have irregular supplies of opioids, who are getting some that are stronger and weaker and they don't know, and maybe using other drugs sometimes but not all the time. This puts people at extra risk, and this is one of the highest risk groups of people. These are people who may be using prescription opioids not the way they're prescribed. This may be people who are using heroin. This may be people who think they're using heroin but are actually using a synthetic drug, fentanyl, or closely related compounds to fentanyl. These are also people who should probably have overdose treatment kits and whose friends and family should be aware of these kits and know how to use them. The person who has an overdose is not able at that point to use the kit. So it's really about the people around them knowing that the kit is there and knowing how to use it.